computer. Okay. All right. Okay, so hello everybody. So Bismillahirrahmanirrahim. Now we are moving to our third lecture, which is update on latest Bppv maneuver. So as far as we know, the Bppv is the most commonest peripheral vestibular disorder, and the most commonest site is actually posterior semicircular canal. And you can see here, because of the what we call gravity effects, actions, everything, the posterior canal is the most common affected canal compared to another canal, which is anterior and also horizontal semicircular canal. So any displacements of the otocornea inside the semicircular canal can cause a symptoms, which is among our patients, for example, like positional vertigo for a few seconds, nausea, vomiting, and so on. All right. So as you know, Bppv is the most commonest vestibular disorder. 2.5% people prevalent will have experience in some point of their lifetime, and Bppv is actually account for at least 20% of diagnosis, and then made by physician who specialize in disease. But the most important thing before this, we always say Bppv can be diagnosed as history by history taking. But for me now, after I have seen a vestibular patient for almost 14 years, history is not enough. Because sometimes when people prescribe to you, explain to you the features of the Bppv is look like Bppv, but when you do the HOPA, it's not, you know, because there is a very common symptom actually when we are moving from lying, you know, from lying to sitting up position, they will have vertigo and so on. So this symptom is actually, if you are not done the HOPA test, you cannot diagnose them as a Bppv unless you have proven or unless you have done the HOPA test. So Bppv can only be diagnosed after this HOPA test. So all people that since vestibular or vertigo patient, you need to do this HOPA test at least. And as you know that the HOPA, we have lots of method, which is like a modified HOPA, the HOPA, side lying, and so on. So we will cover in this lecture soon. And then 50% dizziness in older people, and you can see here, according to this, what we call Bppv at Chicago, dizziness and hearing by age. The more older people, the more higher people to have Bppv. And 60 years old is actually the peak age, and more than 60.4% populations have Bppv every year. This is according to Lampert 2009. And you can see here, Bppv is actually typically unilateral. It's a very rare bilateral cases reported in that we can see 81 and also 81% to 90% of all cases is actually in canalis and the posterior canal, and women are more common than men. And if you can see here, the incidence of Bppv among a canal compared to the canal between the posterior horizontal and anterior canal, the posterior canal is actually the most commonest one compared to other. And even we have seen this in this slide, which is a serial, what we call a serial research done, and it shows posterior is the most commonest. And what we're going to do when you have a Bppv patient, the most important thing is actually what happens is actually when you move ahead, the crystal are moving inside the semicircular. So that's why there is a sense of false message to the brain, and people will experience what we call a spinning sensation, or this is what we call vertigo. Vertigo for Bppv is only few seconds associated with nausea, vomitings, and it's a positional related. Positional related is a horizontal when they turn from right to left, and when they are like posterior canal, they are more to the from lying to sitting position, something like that. So can Bppv come back? Of course, yes. Even the successfully treatment or how good your treatment, majority 1/3 patient will have symptom recur after 1 year. But it depends on mode or maneuver that you choose. For example, like if you are seen before, these people use a lot Bppv maneuver. The Bppv maneuver is really, it shows the recurrent rate is 2 years. After 2 years, people will come back to you. So this is not really good for patient itself. You know, it's for them to come back and to experience all the symptom again. But for what we call, if you use gun CRM, gun canal repositioning maneuver, or if you use Semen Maneuver, the recurrent rate is more longer, which is people will come to you after 4 or 5 years. So this is very good, and I think for me it's a good option for people that having what we call for people that having the Bppv, posterior canal Bppv, and so on, and 50% are recur after 5 years. So this is quite common. And if you can see here, the pathophysio of this semicircular canal is actually the orthoconia shift to the semicircular canal. It can be caused by what we call a cause of sensitivity to change in gravity, because the posterior canal, the position here you can see is a most lowest, and if anything happen or occur in the brain, or for example like head injury or head concussion, what will happen is actually the orthoconia will move down inside the posterior semicircular canal, and that's why people will experience of the symptom of BPPV. And there are a few types. There are free floatings, and this is what we call canalitis, and there are also a few method which is attached to the cupula. This is what we call cupulolysis. And we can see here a few BPPV variants here, or there is a few theories says that 1969 there is like the theory of cupulolysis, orthoconia shift to the cupula. So that's why during the maneuver you need to wait. You need to wait. The issue is when you do the whole part test, you need to wait in every position. In every position, when you do the whole part test, you need to wait at least for 1 minute or 60 seconds. So this is just to give a time for cupulolysis to came or to present their nystagmus. So no longer, but I think this story is actually no longer believed to be activating the response. And according to Pames and Macklow, 1992, and if you can see the loose free floating, this is what we call canalitis. So whatever you see, orthocorneal debris is a free floatings in the canal, which explain why virtually all CRM protocol are successfully. So this is what we call canalitis. This is the most commonest type of the BPPV. The symptom, I think everybody is already familiar with the symptoms of BPPV: vertigo, dizziness, imbalance, difficulty in concentrations, nausea, changing in head position with respect to the gravity, posterior semicircular canal, for example, then when they are looking out, rolling over, and also rolling over, which is more to the horizontal BPPV, getting out of the bed, this is more to the posterior canal or anterior canal. But as I always told my student, where the most commonest is a posterior. If you are confusing, because anterior canal is a downbeating, a rotary downbeating nystagmus, and if a posterior canal is actually rotary upbeating. So the different types of the movement of the nystagmus can be different diagnosis. So if you are not sure, I think because majority is a posterior, you can assume this is posterior and you can choose the best maneuver to treat them. So very short duration is maybe last a lifetime. Okay, when we are talking about etiological factor, age is actually less than 50 years old. For young people, head injury is more common. Age which is more than 50, which is BPPV, is most common as idiopathic and age-related degenerations of the autolytic membrane. And BPPV is also associated with migraine and ototoxicity, and also virus affecting the ear, which is vestibular neuritis, and Meniere disease can be unusual cause, and also BPPV also can cause by surgery of the inner ear, for example, like CI, or any use what we call a vibrator during the operation. So this is actually, and also it can be during the procedure combined with a prolonged supine. And I have seen a lot of like post-stroke people who are lying flat for all time. They're prone to have this BPPV, and BPPV also can cause by long period of inactivity. And also in terms of diagnosis, as I said before, the thorough examination with medical history, physical examination, the result of vestibular and auditory test is very important, because BPPV there is no hearing involvement. And to be honest to you, there are lots of confusion when people came to you with vertigo. Many people will direct patient to do MRI first. I think this is not really good, because of course when you are before this, when you are talking about nystagmus, you are thinking about central. But in BPPV is actually peripheral vestibular disorder, and actually MRI you need to think very cautiously, because it's going to be very cost to patients. So if you think this is BPPV and not central, please don't do MRI or CT scan. Okay. The Hopart test maneuver and supine roll test, Fraser Google's VNG. So this is a few tests that can help people, and Fraser Google is good to visualize the types or directions of the nystagmus, for example, like upbeating or rotary downbeating. All right. Then when you are talking about MRI, to rule out for such other like stroke, brain tumor, that's fine. But scan is not helpful in the diagnosis BPPV. And other treat size is also actually good. Actually, you want to exclude is there any Meniere's labyrinthitis and so on. And a few nystagmus, actually you can There's a lot of in YouTube. You can see the nystagmus type, which is rotary up beating, rotary down beating. Rotary out beating, which is more to the posterior canal. Rotary down beating, which is more to the anterior canal BPPV. And horizontal nystagmus during the roll test is actually diagnosis for horizontal Bppv. Okay, technique. We are talking about the symptom, and that's why I'm emphasized here. All vertigo patients must to do this Hopite test. So there's a few types of Hopite test, which is what we call Dix Hopite test. Actually, everybody very familiar. And the second one is modified Hopite test, which is a good for body mechanism for clinician, actually better support for patient also, especially for those who are having back pain, because it's try to eliminate the bending the waist and hyperextensions of the neck when you use a pillow, because in modified you use a pillow. And I think for those who are always come to my what we call workshop or masterclass, you are very familiar because we have done all the practical and so on. And side lying also one of a very important which is able to eliminate and bending, and fully support is actually use support everything. So this is in case of risk of bacillus, atrial stroke, roll test, and also lateral body positioning also very important in order for you to exclude any horizontal canal. Okay, so this is actually the whole pipe test and roll test. Roll test is actually for horizontal canal, but for this whole pipe test, modified whole pipe, side lying, everything, and fully support whole pipe test is an assessment for anterior and posterior semicircular canal. All right. So when you're talking about modified, it's actually a support similar and maximize the comfort to patients, and also you can visualize patient's eye very easily. And then if you are fully support, it's similar to modified. It's just you support patient neck and head fully, and to avoid that means to try to minimize hyperextension of the neck, and useful for patients with positive VAS and also cervical spine issue. And side lying is actually avoid issue of vertebra artery compressions, and also ideas for patients who cannot bend at the waist, lower back lumbar problem, and also similar to position of Semen laboratory maneuver. We show the video after this, and patient is placed on their side with their head turned away from test ear. And I think when you're doing this Hopite, there's a lot of issue. And the most important thing, before you do the Hopite test, you need to make sure the patient was not having any cardiovascular risk. For example, like if patient having history of discharge from ICU for 1 week or 2 weeks ago, no, you cannot do that, you cannot proceed. And if you want to do, you have to have what we call a proper, which is emergency trolley, everything, and you need to be supervised. And I send this message actually because now in Malaysia, I know there's a lot of physiotherapists, lots of audiologists now practicing do the Hopite, but you have to be very careful. If you are not confident enough, you should refer to a medical officer or medical specialist, which is ORL specialist or neuro. Because I am from neuroscience department, I'm working with a lot of neurosurgeon and neuromedical. I think we are working together. So if you don't feel so confident, you need to have a medical doctor beside you. All right. And it's very dangerous because this test is actually provoking, and also explanation is very important. I have seen a lot. And the most important thing, when patients are very scared and panic, if you don't give them a proper explanation, patients are risk to refuse. What I mean refuse here, actually patient try to wake up. If you try to lie down, patient try to wake up, and all those things will disturb. All those things will impact your management, because if patient wake up, if patient refuse to follow your instruction, is very hard. Okay, and you can. Okay, we can see here, this is a Semen Maneuver. This is an example. You can see here. Okay, this is a Semen Maneuver. That's what the reason why I'm telling here, because women is actually the lowest recurrent rate. You can see. Good. This is before COVID. That's why we are not wearing masks. All right. This is before COVID. So this patient doing Semen. Okay, so this is Semen Maneuver. So the first Semen Maneuver is actually rarely practiced, but because you have to, after you do the hopai, and you have to sit up patient on the batch of the batch. But I think you should try. If you are failed using Apply, if you are failed using gun, you can practice. You can try to use Semen. All right. So we are talking about roll test. It's actually a test. It's not hopai. It's an assessment for horizontal, and there's a patient roll on the side. It's a very simple movement, where people nystagmus is more to the linear if they are positive, and fast towards the undermost ear, which is a geotropic and a geotropic. All right. So if you can see here, I can conclude here Bppv finding. If you are like torsional right and torsional left, this is more to the right canal and the left canal. Upbeating posterior, downbeating, which is anterior semicircular canal. So this is a basic concept that you need to be always in your mind. You know, when you are doing with a Bppv patients, the duration which is less than 60 seconds, which is canalitis, more than 60 seconds, which is cupulolysis, and horizontal canal, which is a geotropic, and a geotropic, which is what we call canalitis, and also a cupulolysis. So this is a thing that you should always remember, because you know that's why the concept of weight, because for some latency is a really, really important. And if I want to make not conclusion, is summary for posterior semicircular canal, is actually the treatment procedure. The treatment procedure is gun CRM. And to be honest, I'm not using Apply so much now. If I fail gun, I use Apply or Semen, but I always use gun. The reason why gun is actually gun, there's not much difference between gun and modified Apply or Apply maneuver, because the Apply maneuver is no shaking, but during gun, normally we use 4 times shaking. A confident shaking, small angle, and downward, which is 1, 2, 3, 4, something like that. And I have I think in YouTube also there's a lot of video, and also we have also compilations of this update on Bppv for all the maneuver, because for this 30-minute durations lecture, I think I can't show all the video. And the second one, Semen. And if I just to share my experience when I was in US, I think 2016, they mentions that in Europe actually they don't use Apply anymore, because Apply the recovery rate is actually quite high, which is after 2 years people come back to you. But for Semen actually is to like the recurrent rate percentage is quite low, which is less than 4%. For gun, which is like 4 to 5%, and for Apply the recovery rate was 20%. This is a very high. And then for cupulolysis, which is you can choose laboratory maneuver, and also for anterior semicircular canal you can use deep hanging maneuver. Deep hanging maneuver, if you click in YouTube, you can see it's a very simple, and for anterior canal Bppv. But should remember, anterior canal Bppv prevalence is very low compared to the posterior canal, which is more to the 80 to 85%. For anterior canal, which is like 11%, something like that. And horizontal canal Bppv also more lowers. But you should know, if in case during my experience for the 14 years, I have seen 2 cases only for anterior canal, and horizontal canal I think I have seen 1 cases, and the rest are posterior canal Bppv. And for the horizontal canal Bppv, we use a barbecue maneuver, and canalitis, which is Appiani, and for the cupulolysis, which is Cassiani. But if you don't remember about Appiani and Cassiani, this is another method, and the latest method that teach by Prof, I think Prof Gunn from American Institute of Balance, and also Brandarov. If you don't remember, you can use Brandarov for canality and cupulolysis. But I just want to highlight here, because I have seen a lot of practicing or clinicians in Malaysia or physio, they ask Bppv patient to do maneuver, Brandarov maneuver at home by themselves. I don't agree with this, because if you are people doing at home without their clinical experience or knowledge, this is going to be effects of the shifting to the other canal. So please, I think you should stop advise people to do any exercise or maneuver at their own at home, because I have seen a few patients just came to Kota Baru, Kelantan, and see me after they said before this they was under certain management in certain center, and they was advised to use Brandarov exercise, and then they have to do 2 times or 3 times per day. I'm quite scared to hear that, but I think it's not. I think for me at the moment the best option is actually for Bppv. You have to come and you have to you have to do with the clinician. You have to come and see ORL specialist. You have to come in USM. We do have balanced rehab clinic, which is under me, which is the Dr. Zuraida Zainun, under neuro department. So that's all. And also, I think now we are training a lot of MO, medical officer, who are expert in doing this, not to do on their own at home. Okay. So when you are saying about horizontal canals, what we do is actually when you do roll test, which is a positive, there are two types, which is geotropic and also agiotropic. For geotropic, which is more to the canalitis, and for agiotropic, which is more to the cupulolysis. And this is the treatment can be Apiani, barbecue minute roll, and also treatment which is Cassiani and barbecue roll. So if you don't remember, you can just use barbecue maneuver. Okay. Okay, and if you are talking about Bppv posterior canal treatment outcome, you can see here, the top one is actually, if you can see what we call Semen laboratory maneuver, and you can see here the percentage recurrent was 4%. And aptly, which is 30%, 20 to 30%, this is quite high. And if you can see here, gun canal maneuver, which is 5%. So when you want to choose the most optimal maneuver, actually, you need to choose the lowest percentage of this maneuver. So if you can see here, the lowest one was 4. I'm not condemn people who are using EPI. Yes, you can use, but I think if you can see from this outcome, you will be a bit scared. You know, because people will come back to you after 2 years. Compared to the like gun, it took more time, which is 4 years and after years. This is according to my experience. All the cases since 2016 when I back from US until now, less Bppv patient came to me within 2 years or 3 years. At least 4 years they come back. But for Semen, they will come. They become. I rarely practice, but I think I'm pretty sure that the effect is good as gun. But for aptly, after 2 years or after almost 2 years, 1 year plus, they come back to you. So that's why when you're choosing the best maneuver outcome for your patient, you need to choose the most lowest recurrent rate. Okay. So when you are talking about provoking test, this is a provoking test, statics and head shaking. So you have to be assured and understand the direction feeds, direction changing, and all those things, because you want to know whether this is a peripheral or central, geotropic, agiotropic, and persistent, and other transient, nausea, dizziness, and position. Also, this is a more important, and also head shakes only even negative, and then looking for this is a few issues that you can see. And during this summary, I really love this picture is actually to be a clear understanding. What is assessment? What is treatment? When you're talking about assessments, big hot part test, modified hot part test, side lying, fully support is an assessment. So treatment, it can be aptly, gun, Semen maneuver, deep hanging maneuver, and also for roll test, assessment is roll test. Treatment will be barbecue maneuver, Apiani, and Cassiani. So take home message, all vertigo patient you need to do this whole bite test. Why? Because in order for you to choose the best treatment, is actually you need to know whether this patient is a Bppv or non-Bppv. All right. So this is our reference, and I think I almost like reaching 6 minutes to the like 30-minute lecture. So I think thank you so much. But no worries if you want. We do have Bala X have compilations of the update Bppv maneuver, the whole video about gun, CRM, site line, supan, everything in the video. So you can contact our staff at the end, which is Miss Azli Hanis, or you can email me in drzuraida@yahoo.com, and also our staff, which is 011 33558238. All right, thank you so much. I think I end up this lecture with thank you so much, and I think this is my last lecture, I think, for today, and best of luck. And I really hope whoever you are, whether you are audiologist, physiotherapist, or you are ORL specialist, and whatever, our main goal is actually we want to treat and help all vertigo patients in optimal management. This is the most important thing, because when I'm saying about Bppv, you don't do balance exercise. You don't give them to do exercise. No, Bppv is a maneuver. It's a one-off treatment. There's no medication need after that. If your patient still need medication, even you do the maneuver and so on, so this indicate your treatment is not optimal. So that's why I'm saying to you again, please be careful and please treat patient properly. Choose the best optimal maneuver. Choose the best and try to avoid to ask patient to do Brendarov exercise or whatever, or follow. I think lots of in YouTube now. Please don't. Please avoid that, and please ask them to come and see you at least to get a proper management. All right. Thank you so much. And yeah, thank you so much.